welcome to the EMSNation podcast. I'm your host, Faizan Arshad. In June of 2016, in our home state of New York, we had a very historical act, and that was the passing of the New York State Collaborative Protocols, where 13 out of the 16 regions in New York State elected to adopt an evidence-based, cutting-edge protocol which was expansive and incorporated all 13 regions which elected to join, standardizing the pre-hospital process at the CFR, BLS, ALS, and critical care levels. Today, I'm ecstatic to have on our podcast Dr. Chris Fullagar from Syracuse, New York. Welcome to the podcast, Chris.
Well, thank you very much, Faizan. I'm very happy to be here.
Chris, you played an instrumental part in developing the state collaborative EMS protocols. We're in fact here at Laerdal headquarters in Wappingers Falls, New York, where we had an incredible day recording a bevy of simulation videos designed to enhance the training and performance and new skill acquisition of our pre-hospital providers across the state. Would you provide some insight into why the collaborative protocols were so important? What was the critical need, and why we're so excited that this actually happened?
Well, across the state, we have a lot of people who have a passion for emergency medical services. These people have experience, they know what the goals and the limitations are of pre-hospital care, and we had people really come together to provide some excellent insight into the protocols. I'm personally very excited about what we have, and I'm very happy to be part of the rollout as well.
So in regards to the rollout, one, the collaborative protocols are historic. Two, the rollout is also historic because we have a compendium of educational resources that are going to be freely available to providers all across the state, and in fact, anybody who wants to generally consume these products. The podcast is not going to be inclusive of all the protocol updates and changes, but it's certainly going to talk about some of the highlights that we had along the way and significant changes. Can you just briefly mention all the other training options that are available?
Yes, as part of our rollout education, we're also going to have some videos, we're going to have some didactics, we're going to have a protocol exam. All of these things are going to work to try to make sure that the providers are comfortable with the new protocols. As you mentioned, this particular podcast is not all encompassing, but one of the main goals, I think, of this is a lot of people have questions as far as why things were done in certain ways, why did the protocols turn out to be one way and not the other, and the hope is to discuss a little bit of the thought process, especially if some of the procedures are a little bit different than what the providers are used to.
Fantastic. And in the past model, when a region would make an evidence-based change, they were then subsequently responsible for creating the education that accompanied that. By consolidating the protocols to 13 out of the 16 regions, one, we can be evidence-based, and two, in terms of educators across the state, we can join forces and develop extremely high quality educational and training materials, which should elevate the care all across the state, and indeed for other providers who choose to participate and learn some of the things that we're teaching. So just to jump right into it, the podcast is designed to highlight some of the nuances of the protocol changes, and we wanted to start out with the medical control agreement.
Yeah, so the medical control agreement may be a little bit of a paradigm shift to some providers out there. Essentially, we are evolving from the 1980s thought process that the protocols are to be followed like a recipe. Instead, there's the understanding that we can't write a protocol for every single nuance that a provider may encounter in the field. In addition, we spend a lot of time educating providers to give them knowledge to make good decisions for patient care. The protocols are not a substitute for good clinical judgment. And it's important to make sure that they are as flexible as possible to accommodate the complexity of patient management. What the medical control agreement does is essentially allows providers to utilize their best clinical judgment and deliver care and procedures according to what is reasonable and prudent for specific situations. Now, this does not mean that medical control is superseded. Instead, any deviation from the protocol needs to be documented and reviewed according to regional procedure. In one sense, this is going to be a way to address the radial failure or an inability to contact medical control, but it is in no way meant to negate the need for real-time medical control, but allow the provider to use their education in order to make sure that the best care is delivered to the patient. The individual regions are going to determine the procedures that will be taken within their jurisdiction for deviations of protocol.
Understood. So, in summary, we're highlighting the importance of clinical judgment of the pre-hospital care provider, but it is not necessarily an exemption from calling medical control or seeking further direction from online med control.
Absolutely.
Fantastic. So that being said, we're going to jump into the meat and potatoes of our first podcast, which is essentially going to discuss various aspects of cardiac arrest management, return of spontaneous circulation, post-intubation sedation, pediatric cardiac arrest, all very enticing topics that I'm sure you're going to enjoy listening to.
Yes. Just jumping in with the general cardiac arrest care, which essentially is the first protocol, 1-1. And the main thing that I think is important to emphasize is that high quality, uninterrupted compressions is really the mainstay of excellent cardiac arrest care. This is something that we oftentimes don't pay a lot of attention to, but can affect the outcome of the patient more than anything else that we do. So it is much more important than any of the medications, the interventions, the IV, the intubation. We really need to make sure that we focus on good quality compressions, push hard and fast with 100 to 120 compressions per minute, and make sure that we rotate the compressors as often as we need to. There have been some studies that have looked at the effectiveness of compressions, and even if people don't feel particularly tired, after about 2 minutes, it's fairly consistent that the quality of their compressions goes down. So if you do have the personnel on the scene and the resources to be able to do so, the person who is running the code should really be cognizant of that 2-minute mark and try to make sure that we rotate the compressors as often as we need to.
I think that point cannot be emphasized enough. We know that across the country, there's a wide variation in the quality of CPR that's administered by pre-hospital providers, including the rate of compression, the depth of compression, as well as allowing for adequate recoil, which are difficult concepts to teach. And in fact, providers must be proactive and undergo at least quarterly training to optimize their CPR performance. We know that there's a wide variation in ROSC rates for witnessed VF across the country. Some people who undergo witnessed VF have greater than 50% intact neurologic hospital discharge rates, whereas in other parts of the country, that may not be the same. While there are a host of reasons why this may be true, I think it behooves us all to focus on cardiac arrest training and implement high-performance CPR systems, which can certainly benefit our patient population.
Absolutely. And along those lines is the concept of continuous compressions with asynchronous ventilations. Now, a lot of us are used to doing continuous compressions while ventilating the patient when the patient has a definitive airway in place. So if the patient is intubated, we are going to continue doing compressions without regard for stopping in order to ventilate. Now, it's not as common for us to do that when the patient is not intubated. So when we are utilizing a bag valve mask, we oftentimes will stop in order to deliver the breaths. What the protocols allow you to do now is the ability to engage in continuous compressions, even in non-intubated patients. When you do that, it's more beneficial to try to ventilate on the upstroke, but the overall goal is to minimize these interruptions, which can have an effect of decreasing the rate of ROSC, or return of spontaneous circulation. We want to approach this in a pit crew type of a fashion so that everybody has clear understanding of what their responsibilities are and their roles are in that code scenario.
Fantastic. We know that feedback devices certainly improve our CPR outcomes. And there are a lot of fancy new defibrillators and in fact AEDs. All the major manufacturers include CPR feedback devices, which can tell you if you're pushing too hard, not pushing deep enough, not allowing for adequate recoil. If your service does not have a CPR feedback device, simply downloading a free metronome app on your smartphone can dramatically improve your chest compression rate. We know that when we study providers who are performing chest compressions who don't have feedback, the rates can be widely variable, and that harms patients. So we really want to hone in and be tight somewhere even between 100 and 110 chest compressions per minute. We know the AHA recommends anywhere from 100 to 120. So we can certainly do a lot better in terms of giving ourselves feedback, and it doesn't have to cost a lot of money.
One other thing to consider in regard to minimizing the interruptions of compressions and providing good quality compressions is to try to avoid doing compressions in a moving ambulance. Number one, whenever we try to do compressions in a moving ambulance, it can be dangerous. We're oftentimes standing up, we're not seat belted, but the other thing is that it compromises the quality of the compressions. It can be very difficult for the providers to switch in the back of the ambulance, and it can also be very difficult to provide good compressions because a lot of times you're holding on to the bar over your head to stabilize yourself, and you're only compressing with one hand, and that doesn't lead to very good results. Trying to work the code on the scene, if you absolutely have to transport the patient, considering the use of a mechanical CPR adjunct like an auto pulse or a Lucas device, even though there may not be good studies to indicate the superiority over good quality CPR in the back of the ambulance, we know that it's very difficult to maintain, so this may be a good alternative in this environment.
Certainly in the transport environment, it's not safe for the provider to be doing chest compressions in the back of the ambulance, and safety from a medical director's perspective is tantamount for the providers. Now, you also wanted to touch base on waveform capnography and hypothermia and cardiac arrest.
Yes, in regard to the waveform capnography, we can use that when a patient is intubated, but we can also use that when we are using BLS ventilation methods. The waveform capnography itself can reflect the effectiveness of resuscitation in that if there is a sudden spike in the end tidal CO2, that may be a good indication that you may have achieved ROSC, or a return of spontaneous circulation. Also, it can have a reflection on the quality of your compressions as well. And you mentioned that I wanted to discuss hypothermia briefly, and the reason why is because at the end of the protocol, we have certain things that we recommend if we have a person who we are resuscitating who is hypothermic. Now, in this case, we're not talking about therapeutic hypothermia. We're talking about a patient who might have been found out in the elements, and clinically you feel as though they may have a low core body temperature for whatever reason. Now, conventional wisdom dictates that the hypothermic heart is less responsive to cardiovascular drugs and defibrillation. Now, there's some animal data to bring that wisdom into question, but there have been no human evidence studies and a relatively small number of animal investigations. So for now, the recommendations are that we would deliver one shock if it's necessary and limit to one round of ACLS medication, with the focus being on compressions and BLS care.
And in regards to obvious death in the setting of hypothermia?
In the setting of obvious death, there may be indications in which the patient may not be able to be rewarmed. The old dogma of the patient is not dead unless they're warm and dead may be something that is not achievable. A lot of times, if we were to do a resuscitation that lasts for an hour or so, even if the patient is hypothermic and may have been submerged, the outcomes after that are generally not very good. So there is a protocol that allows the paramedic or the provider to stop CPR in certain instances, which are considered futile.
Understood. So moving on to Protocol 1-3, VFIB Arrest. We wanted to discuss briefly the precipitate which can form if calcium chloride and sodium bicarbonate are administered too quickly or successively without dilution, or an S bolus in between.
Yeah, it's important that whenever we are in a situation in which we have to administer calcium chloride as well as sodium bicarbonate, if we need to give it in the same line, we want to make sure that we instill a minimum of 50 cc's of normal saline in between the two boluses. And the reason being is because if both of those medications come into contact with each other, they can precipitate out in the bloodstream, and we certainly wouldn't want that to occur. The other thing to consider along similar lines is amiodarone. If we are to give a dose of amiodarone, we generally would like it to be diluted in a minimum of 20 cc's of normal saline. And the reason is because we want to try to minimize post-ROSC hypotension as well as phlebitis that can occur with a rapid administration of high doses of amiodarone. So those are two things under the general key points that I think are worth pointing out, because I'm not sure that every provider is aware of the reasoning behind those.
Fantastic. And then within the VFIB Arrest protocol, I also wanted to briefly mention double sequence defibrillation for refractory VF. So the last thing in the VFIB Arrest protocol that we briefly wanted to mention was double sequential defibrillation. Now, double sequence defibrillation is the implementation of two devices, either an AED and a defibrillator, or preferably two defibrillators, to administer near simultaneous defibrillation shocks for your patient who is in refractory VF. And refractory VF means they've been shocked multiple times, they've received ALS, epinephrine, as well as an antiarrhythmic, and nevertheless, their rhythm remains unorganized in ventricular fibrillation. So the literature is based primarily on case reports as well as now case series in several services across the country, but using an additional defibrillator may potentially convert our patients to an organized, normal, spontaneous rhythm. To learn a lot more about this concept, as well as to watch a simulation video where we demonstrate this new modality and skill, stay tuned for our protocol update simulation videos to be released in January of 2017. So moving on, Chris, we have Protocol 1-4, ROSC, Return of Spontaneous Circulation.
So in regard to the return of spontaneous circulation, we want to make sure that we optimize the patient's condition prior to transport. We want to try to prevent the patient from going back into cardiac arrest during transport. We know that when we have a patient in cardiac arrest in the back of the ambulance, it may be very difficult to provide good quality CPR, which we know is the most important thing in regard to trying to optimize the patient's outcome. So we may want to invest a little bit of extra time to do a few things prior to putting the patient in the back of the ambulance. One of the important things is to acquire a 12-lead ECG. And while we want to make sure that we minimize the delay in patient care for diagnostic procedures, this is one that's probably worth spending a little bit of time on. If you do identify a STEMI or an ST segment elevation MI in a patient who has return of spontaneous circulation, that is a strong indication that the patient should most likely be transported to a facility that can do an emergent cardiac catheterization. At the very least, if you do identify a STEMI in a patient who has ROSC, then you should be speaking with medical control to help to determine the most appropriate destination for that patient.
I think you bring up a great point. We have a patient who is in an out-of-hospital cardiac arrest, and because of excellent pre-hospital response, they've now returned to a normal spontaneous circulation. So it behooves us not to undo all the hard work we just did and optimize our patient's hemodynamics. So if their MAP, their mean arterial pressure, is not 65, or their systolic blood pressure is less than 100, in other words, they're hypotensive, we should certainly continue the resuscitation for that patient by administering crystalloids, as well as considering the initiation of norepinephrine infusion.
Yes, there's the old paradigm in EMS of the decision as to whether or not we should stay and play or load and go. And I recently heard of a saying in which we should really not consider either of them, but considering stopping and thinking in order to determine the appropriate balance for that particular patient in that particular scenario. And that's one thing that the return of spontaneous circulation protocol addresses, in that there may be certain things that we want to focus on before we rush and transport that patient to the hospital.
Excellent point. The next thing I'd like to bring up is actually not in sequential order. It's protocol 2-34, which is post-intubation management. But nevertheless, in our patient who we've just achieved return of spontaneous circulation, and we have to now secure an advanced airway if we haven't done one already, we have to remember that all across the country, and indeed all across the world, we need to do a better job of educating providers that intubation is inherently a painful process. Having a tube through your trachea is not comfortable. So we've expanded the protocols to have post-intubation analgesia measures, which are new in terms of the paradigm shift, fentanyl on standing orders for medics.
The one thing I wanted to mention about this protocol of post-intubation management is that this protocol is for everybody. This is not a protocol that is specific to those who have regional RSI credentialing. This protocol should be used for every patient who has been intubated, regardless as to whether or not it was done by a quote-unquote RSI paramedic. So in this case, as you mentioned, in the past, we have focused on the sedation of the patient who has been intubated. But what we've been learning is that we should probably be thinking a little bit more about pain management than the sedation. In regard to post-intubation management, you mentioned that we are to use fentanyl. And according to the protocol on standing order, we should administer 100 micrograms of fentanyl IV, and then we can administer 50 micrograms IV every 5 minutes as needed. Now, this is limited somewhat by the amount of fentanyl that we can carry on the ambulance. So if you find as though you are taking care of a patient and you are essentially running out of fentanyl and may need more, it's important that you document that and let your regional program agency know about that so that we can consider the need and the ability to increase the amount of fentanyl that we carry on the ambulance if we find as though this is an ongoing issue. In addition to fentanyl, we can also provide sedation, and that sedation can be given either by a benzodiazepine such as midazolam, or if you do have the ability, preferably by ketamine.
And I know personally, and for several agencies within my region, we have been strong advocates of ketamine because of the multitude of uses of this particular drug within the pre-hospital environment. Ketamine, in a dose-dependent fashion, offers both analgesia as well as sedation by means of dissociation, and in fact has become my preferred induction agent of choice. So if I am performing a pre-hospital RSI, I do typically have ketamine handy, but certainly fentanyl is a go-to because we should focus on analgesia as a learning point over sedation in a post-intubation setting.
Absolutely. And the other thing about ketamine is that it has a very favorable hemodynamic effect in that the patient will not have as much in the way of hypotension when you give this medication compared with other alternatives that may produce hypotension more frequently. In regard to post-intubation management, another thing that I wanted to bring up is the use of the OG or orogastric tube. It's important to consider this if you're equipped to do so and regionally approved to place the OG tube. Even with a definitive airway, meaning a cuff tube in the trachea essentially, that does not completely prevent the patient from aspirating. If the patient were to vomit, they can still get the gastric contents in the lungs even with an endotracheal tube in place. So whenever we can, it's important to try to decompress the stomach to help to prevent aspiration.
That's a great point, Chris. Another thing while transporting these patients is complications of the intubation procedure itself, and sometimes patients become difficult to ventilate. How do you approach this type of situation?
Patients who are difficult to ventilate when they are intubated represent a patient population that essentially have a very critical process going on. You have to make sure that we address this quickly and effectively, and we oftentimes have mnemonics that are thrown around for various things in the pre-hospital environment. But this particular mnemonic, I think, out of most of them, is actually worth committing to memory, and that's the DOPE mnemonic, DOPE. In this case, D is for displacement, and if you're having difficulty ventilating or oxygenating the difficult patient, it could simply be because the endotracheal tube has become displaced. So checking the position of the tube is important. The O is for obstruction, so if there is a mucus plug, for example, or something else that's obstructing the tube, that can certainly prevent your ability to adequately ventilate the patient. The P is for pneumothorax, and in particular what we're talking about here is a tension pneumothorax. And it's important to remember that patients who are being ventilated with positive pressure have an increased risk of developing a tension pneumothorax. You are ventilating the patient by essentially pushing air into the lungs, and if there is a defect in the lungs, that positive pressure air can escape into the chest cavity and increase the intrathoracic pressure. That intrathoracic pressure can make it difficult to ventilate, and it can also decrease the patient's ability to perfuse. E is for equipment failure, and this is a fairly simple thing to correct if you recognize it. And the E is there to remind you of the simple things, like a disconnection of the bag valve mass from the endotracheal tube, or a deflation of the balloon on the end of the endotracheal tube. While these things are easy to correct, you can't do it unless you recognize it. So the E is there to help you to remember it. So the DOPE mnemonic is one that I use and one that I think is extremely important in this instance in which you really cannot miss any one of those potential issues.
Now, another situation with equal or greater criticality is that of pediatric arrest. And the point that we'd like to discuss is the approach to the advanced airway in your pediatric arrest. I think dogma has been that because many pediatric arrest situations tend to be respiratory in etiology, that they need a definitive advanced airway, meaning endotracheal intubation. Nevertheless, that's a difficult skill. It's not practiced or trained upon often, and we have an evolving literature base which questions the advantages or benefits it may have for patients. In fact, taking time to intubate a patient may harm children rather than prioritizing effective BVM, oxygenation and ventilation, and getting them to the hospital as quickly as possible.
This is one that generated a fair deal of discussion. And I think one of the things to keep in mind in this case is that this goes beyond the simple discussion of providers not being able to intubate effectively. This really doesn't have anything to do with the ability of pre-hospital providers to intubate. What this has to do with is that those pediatric patients who are intubated successfully in the field don't do as well as those who are not. And this can be a little bit counterintuitive, but I think that this is an important point. And one of the main reasons why pediatric intubation, even for cardiac arrest, has been taken out of the protocols, provided you can oxygenate and ventilate the patient well with BLS airway management. So we have in the protocols to consider intubation for pediatric cardiac arrest only if you are unable to effectively ventilate with a bag valve mask and basic airway adjuncts.
I think that's well said, and it also reminds us that effective BVM is a BLS level skill, and we should all practice to make sure that we can maneuver a patient to ensure that we're adequately ventilating and oxygenating them, whether that's obtaining an effective mask seal, doing a jaw thrust chin lift, or using adjuncts such as an OPA or an NPA to ensure that we can appropriately ventilate our patients.
And in these cases, focusing on good BLS skills, including good quality chest compressions, is really where we need to be focusing for pediatric cardiac arrest.
Fantastic. So to round out the discussion for podcast number 1 on the New York State Collaborative Protocol updates, we're going to include 2-2 chest pain. And the second podcast is going to focus on medical and traumatic complaints. And we're super excited to dig into those nuances, protocols, topics, issues, challenges, all of the above, and provide you that insight into how we develop these protocols. But to round out today's episode, let's talk a little bit about chest pain.
Acute coronary syndrome or suspected cardiac chest pain is something that we are exposed to very frequently in the pre-hospital environment. And we have a lot of things at our disposal in order to treat these patients. We have aspirin, nitroglycerin, fluids, we have diagnostics such as 12-lead ECGs, and these things are variably effective in assisting the patient through this process. Of all of the medications that we can administer for this, aspirin is the only one that has definitively been shown to decrease mortality in the setting of ACS and myocardial infarction. Specifically, it decreases the number of patients who die from this process. Aspirin has been around for a long time, and those of you who have been around for a long time as well may remember when aspirin was used very commonly to treat the common headache. And the dose of aspirin for the adult was 2 regular strength aspirin tablets for a total of 650 milligrams. And the reason I say that is because people often ask me if they should administer a dose of aspirin after the patient may have taken their own. And my answer to that is that if there's any question that the patient received the aspirin, you should go ahead and administer another dose of aspirin to the patient. It is the only medication that has been proven to decrease mortality, so there's a huge benefit, and it is less than the total dose of aspirin that people would take over the counter to treat a headache, so the risk is also fairly low.
I think that's a great point. And just along the themes of providing highly effective BLS level skills, we should remember that assisting a patient with their own medications is within the BLS scope of practice, and that also could potentially include nitroglycerin for those patients that have diagnosed angina. They can be administered nitroglycerin with the help of the BLS provider. Additionally, certainly if you come from a dense metropolis or highly urban area, a majority of chest pain call types may be ALS call types so that the provider can perform 12-lead ECGs. In New York State, we have an appreciation that we have a diverse variety of regions, providers, locales, catchment areas, and as such, it may not always be possible to dispatch an ALS provider to every chest pain call type. So New York State has also allowed and passed protocols for certain agencies who are interested undergo the training and have the appropriate equipment to perform BLS 12-lead ECGs, which are then forwarded to the base control center or online med control for further interpretation.
I think that's very important and something that I wanted to touch on in regard to the importance of pre-hospital 12-lead ECGs. This tool has allowed providers to have early diagnosis of STEMI, which is the ST segment elevation MI. These are patients who do much better if they can go to a place that can do PCI or essentially go to a cardiac catheterization lab. If we can identify these patients early and get the ball rolling so that the cardiac cath labs can be prepared for these patients on their arrival and the emergency departments can be prepared, we can decrease the all-important door-to-balloon time in order to help to reperfuse the heart. The other thing about 12-lead ECGs in the field are that I've had instances in which the pre-hospital 12-lead ECG clearly shows a STEMI, whereas the initial EKG that we obtain in the hospital is essentially back to normal after the treatment that they received en route. So patients that I've had have gone directly to the cardiac catheterization lab based upon the 12-lead ECG obtained in the field. And if they hadn't had that 12-lead ECG obtained in the field and only had the normal 12-lead ECG that was obtained after they got to the hospital, they may not have gone directly to the cath lab in those cases. The other thing about 12 leads is that these findings can evolve over time. So repeating the 12 lead is also important. Now, Faizan, I recall that you just mentioned the BLS skill set, and that within the BLS skill set you can administer nitroglycerin. Is that correct? Mm-hmm. I've often heard that you should not administer nitroglycerin to a patient that doesn't have an IV line in. What do you think about that?
I think especially at present, it's in vogue to debate nitroglycerin. Can you safely administer nitroglycerin to a patient with an inferior wall STEMI? There's a lot of dogma there and evolving literature based there. But nevertheless, there are many interventions we can initiate within a BLS scope of practice, essentially laying the patient flat, which can potentially safely allow us to administer the medication while also providing the patient some benefit.
I think that one thing I found when I speak with especially ALS providers is that when I ask them about the management of post-nitroglycerin hypotension, they immediately respond with rapid IV fluid hydration. But if we consider this, if we have a line, even if we have two fairly large bore IVs, we know that nitroglycerin is not going to last very long. The effects of the nitroglycerin go away fairly quickly. And in the time that it takes for those effects to go away, the patient really has not received a whole lot of fluid volume, at least not enough to replace the volume that's been displaced by vasodilation. So when we have a patient who has become hypotensive, I think that's a very important point that you made, in that so long as they don't have a contraindication to being supine, like fluid pulmonary edema, that these patients need to be placed in a supine position and lie down flat. I've had many instances, even in the hospital, where a patient has become hypotensive after the nitroglycerin administration, and the staff has the patient with 2 large bore IVs going wide open, but the patient is sitting bolt upright. The patient is pale, is diaphoretic, is lightheaded, and is about to pass out, and feels so much better just as soon as the head of the bed goes down and the brain is now being perfused with blood. So don't forget about BLS interventions for many things, especially this instance, because BLS interventions can be extremely important and have a profound effect on your patient.
That is an excellent and nuanced point, Chris. I'm sure the audience by this point in time is curious and wondering, where can they learn more about the New York State Collaborative Protocols? How can they read them themselves, whether or not they're from New York State? I'm sure we have some listeners from all across the world, in fact.
Absolutely. We are going to have applications available, apps, on both the iOS and the Android platform that would be free to download. They would be the New York State Collaborative EMS Protocols, and you'll be able to access all of these protocols. And within the protocol document itself, we're going to have links to be able to take you to various protocols. If they are referenced in other protocols, we're also going to have links to, for example, normal pediatric vital signs and other resources. So the document itself is intended to be very easy for the provider to use and to navigate in real time.
That sounds very exciting. We will certainly link that up in the show notes when the app becomes available. And I think it's important to remember that protocols are dynamic. They change over time. They change as the evidence base also continues to evolve, and that is the nature of medicine. So it is certainly our intention and the group's intention to create a set of protocols which are able to be employed by a wide swath of providers, specifically in New York State, to provide the best pre-hospital care possible with the current state of medical evidence. So with that, we certainly hope that you guys will listen in to episode 2, where Chris and I will discuss various medical and traumatic call types and chief complaints. Until then, this is Faizan Arshad and Chris Fullagar wishing everyone a safe tour.